Mr. Millenson is a contributor to both Forbes Online, is also on the editorial board of the American Journal of Medical Quality, and a very well-known patient advocate. He will be presenting today on the bizarre business case for patient safety.
Thank you, and I'm delighted, having followed Dr. Kavanaugh's work and a number of the other efforts that people in this call have done. I'm delighted and honored to have a chance to present. And what I thought I'd do this evening is talk about only one slice of the patient safety puzzle, and that's what I'm calling the bizarre business case for patient safety. Now, by way of background, I was one of the first to really write about this topic, starting in the early 1990s, back when I was a reporter for the Chicago Tribune. And when I wrote my book, Demanding Medical Excellence, Doctors and Accountability in the Information Age, which came out in 1997, there was a whole chapter about the patient safety, tracing really the history of studies on it from the 1950s to the present. And I took a look at a couple of the national studies that have been done in the 1970s and 1980s, including the one that the Institute of Medicine would later use from Harvard, and calculated that there were 180,000 preventable hospital error deaths per year. That number was so huge that I kind of backed away from it a little bit in the book's conclusion, but of course we've seen that it was not out of proportion. What I want to talk about this evening is the business case, because what we've seen from the whole history of this movement is that simply publishing articles in the medical literature about patient safety problems and the fact that there are ways to address them is not enough to cause change. No great surprise there. It doesn't work for anything, and it doesn't work for complicated kinds of problems either. So the history that I'm going to present is kind of in that context, and perhaps for those of you who may have interacted with me before, not surprisingly a bit irreverent. So 250 years of economic ambivalence. This is from John Ruskin, the famed social thinker, from 1860. Doctors on the whole desire to cure the sick, and if they're good doctors, and the choice were fairly put to them, would rather cure their patient and lose their fee than kill him and get it. A similar view of physicians came from Mark Twain a few years later, if you read his autobiography. I believe this is one of the earlier indictments of the fee-for-service system. And then you have in 1916, a little bit before then he starts, is a Boston surgeon named Ernest Amory Codman, that I'm sure a number of you are familiar with. But Dr. Codman is the pioneer of what he calls the end result idea. And he is a Boston Brahmin and well respected at a time where there aren't very many surgeons, and he's a Harvard man through and through. And he figures if he just comes up with a way to measure quality, all of his colleagues will embrace it. And his economic justification of having hospitals do those procedures that they're really good at and not do those procedures that they're not as good at is you'll get better outcomes, which he calls efficiency. Uses economic terms, fascinatingly, 100 years ago. For the patient, the mortality and morbidity are reduced. For the surgeon, his illusions are dispelled. And for the hospital, greater economy, and everybody saves money. I'm not quite sure why he thought the hospital saved money or why surgeons wanted their illusions of competency dispelled, but his illusion that everybody would jump to adopt his system were soon enough dispelled. But what this is data that Dr. Jarman of the British Medical Society did for the Institute for Healthcare Improvement that plots on one level risk-adjusted mortality for hospitals and the other level an adjusted cost based on Medicare data, and shows using Massachusetts hospitals, in particular some of the expensive ones from Boston, that you could be very expensive but not necessarily have the best care. So you can see this is a hospital standardized mortality ratio. Thank you, Kevin. And you can see that those 5 hospitals way off to the right are teaching hospitals in Boston, and each and every one of them is the best hospital in the country, except for the fact that they don't all seem to be the same and they cost a lot more than everybody else. So the economic connection between good care and high cost simply isn't there. So this was one of the earliest modern day articles I could find looking at CLABSIs, which I know you have spent some time really studying. And when you look at this, here's an examination of cost and the mortality and a significant economic burden. And you can take a look at some of these numbers and say, what is it today? What's the economic burden? So we're talking about this. This is now a little over 20 years ago. And the question is whose economic burden and whose incentives? So when we look at the cost of it on a national level, these numbers, I think, will catch your attention today because, first of all, they're not really comparable. We don't have anything that's updated. One is lost income and lost household production and disability. The other is mortality and some lost productivity. I suppose you could say that $19-20 billion a year in 2008 is much less than you would expect from 19 to 29 billion in extra cost estimated in 2001. And that if you put that in context of a multi-trillion-dollar medical bill, I suppose you could say that medical costs for medical error are really very minor, and we shouldn't even really worry about them much. I'm not sure that's accurate. I'm not sure that takes into account really the human costs. But I think if you're going to talk about the business case, let's talk about it. All right. So this is where we start in 2004. Let's convince hospitals that no, really, it's causing you money. And this is a company called MedMind, which came up with using artificial intelligence techniques back, a decade ago, to track down infections to their source, individual ones depending on the unit, and use some of that information in order to help hospitals eliminate those infections. And the problem they found in selling their technology was the hospitals thought they were making money off of infections. And so they came up with the idea of coming up with this chart showing the different payment. And they would go to the commercial payers, to the Blues, and they would say, if you pay for 1 year of our efforts at this hospital, we will save you enough money to more than pay for our efforts. And at the same time, they figured within a year they would persuade the hospital administrators that, in fact, they were not making money on infections and be able to sell their services directly to the hospital. And that's what happened. What's interesting about this story is when they would tell it at meetings, public, normal healthcare meetings that we all go to, there would not be a gasp of astonishment from the crowd. Nobody would walk up to the microphone and say that they were stunned that hospital executives would react that way. There would be no anguished discussion that how could this possibly be happening. Everybody knew that this was, in fact, the way things are. And it reminded me of something that Dr. Codman said when his end result idea that was supposed to, quote, make hospitals efficient was not successful at all. And he wrote, for whose interest is it to have the hospital efficient? Strangely enough, the answer is no one. There is a difference between interest and duty. You do your duty if the work comes to you, but you do not go out of your way to get the work unless it is for your interest. And I couldn't help but think about that when I saw this slide, and I think about patient safety and the difference between duty, which I think everyone would agree it's the duty to prevent all medical errors, and what people actually do because it's in their interest. And so we see, again, interest versus duty. One of the pioneers in this area, Rick Shannon, at Allegheny General Hospital in Pittsburgh, who started his effort back in 2004, is writing, again, in the public medical literature, the American Journal of Medical Quality, about how much CLABSIs cost and the fact that the people in his institution, before they really let him go at it, were under the impression that they were a profit center. And so when he actually examined the payments and expenses and he found that they were losing a substantial amount of money, his chief financial officer became very enthusiastic about this. If you look at some of his results, you will see what he ended up with. This is from 2004, a chart that I used at a speech back then, and you'll take a look at how his CCU-MICU aggregate plunged. You'll see this is the Pittsburgh Regional Healthcare Initiative, what they wanted, and then you'll see what the NIS goal was. Look at that enormous difference between what was possible within a relatively short period of time, if you take a look at it, what was the benchmarks going on at the time, and think today, 10 years later, how relatively unambitious we have been given what's possible, given what was shown to be possible so many years ago. If this were breast cancer treatment, do you think there would be this level of inertia? If it were heart attack mortality, do you think there would be this level of inertia? Patient safety is the invisible plague. And this is, again, he looked at beyond CLABSIs to ventilator-associated pneumonia, other HAIs, and this is kind of what he came up with as his return on investment, and they were doing some things with the Highmark Health Plan. Their investment, the ICU admissions, how many lives saved? Since 2006. Is that a good business case? It seems to be a pretty good dollar business case. Seems to be a pretty good lives saved business case. What happened? Well, this is a company called Value Capture, which isn't around very anymore, and the business case is compelling, and they went through some of this data and also, of course, said never substitute for the moral imperative to prevent infections. And I think where we're going with this is not only never substitute, but don't count on it. Was the business case compelling in 2006? Was it the fact that all the hospitals didn't really know their interest and only thought it was the duty? Well, maybe, except that when you look at some of the other medical literature, you see this kind of analysis, which was done in great detail for surgical patients with and without complications. And it's kind of similar to what ended up in JAMA in 2013, the article that was done with Atul Gawande, who's one of the co-authors. And it says reimbursement usually covers their costs, and sometimes it is actually profitable to have surgical complications. Going across my notes, I came across the fact that I'm not the only person who is a little bit frustrated. You're losing money, writes Denise Murphy in 2007. You're losing money, writes Denise Murphy in 2014, a very prominent infection control professional. Maybe, except for the fact that all of us who care about this issue deeply are trying to persuade the hospitals that they should care for financial reasons, and either we've been right for years and years and they haven't perceived their correct financial interests, or we haven't been right. Not sure, but it's an interesting question to raise. Back in 2005, a review of the literature says we really don't have adequate information from the financial analyses. And so we start down the trail of the compelling business case. And I have to say, as someone who's been involved with this for many years, it is disheartening, to say the least, to watch the same language used year after year after year without any resonance and without, frankly, any uproar over the fact that very little is being done, and why do we have to justify it on a financial return anyway? And so the key event, as many of you know, is in 2008, CMS stops paying for never events. It's not very much money that's at risk. And the definition of a never event and which part of the hospitalization they then refuse to pay for is also pretty well defined. So it's not a huge amount of money. But it's a signal, and it starts to get people's attention. And so we write that this should further encourage hospitals. A year later, when a group of writers look at surgical complications, not so much of a compelling business case. Many will need shared savings programs with payers. Not that different from what MedMind was saying in 2004. 2013, another look. Hospitals may have to work with payers to reduce the complication rates. Again, compelling business case. 2014, this is one of my favorites for indignation. You're taking a look at CLABSIs among kids with leukemia and other cancers. And we're looking at the business case for not giving a painful, dangerous, often fatal infection to kids with cancer. That's what this study is about. Not because the authors are heartless individuals. It's because they're desperate to move hospitals off the dime, and they know that interest versus duty is the only way to do it, and so they do an economic analysis, and even then, they fudge it. If all of these costs can be recovered, potentially significant value. And yes, all of these people do talk about the moral case. I don't want to say that they don't. They do, but the articles are making the case they are because they feel it's needed. Again, 2014, the Hawaii study on CLABSIs, hospitals would decrease their margins. BMJ Open article building on that other one from Hopkins, payer support would help. So again, our compelling business case from 2004, 2005, 2006 apparently is not compelling that many people, even with CMS changing its payment rules, even with some of the other kinds of changes that have been going on. Now, this doesn't fully take into account the Affordable Care Act changes, I suspect. And the business case is more compelling, and maybe the social case is more compelling. But it's still very disheartening to look at this history and see the language being used. So let me conclude here with my take on this. I love the conclusions, but I doubt the numbers. I've spent some time in economic analysis, though I don't claim to be a professional economist. And I think that these analyses, frankly, cheat. So they come up with a conclusion that says it makes sense economically to reduce these infections. If you were going to do an amoral analysis, which after all, economics is supposed to be the dismal science, or at least if you were going to do a moral analysis and acknowledge it, you would have to address the difference in profits between killing a patient and injuring a patient. The cheapest medical care is not high-quality medical care. The cheapest medical care is to either kill or cure every single patient on the first day in the hospital. From a theoretical point of view, that's the least expensive, most effective care, because then your medical costs are the lowest. Now, obviously, we can't cure everybody on the first day, even if we wanted to. We could kill them all on the first day, but we don't want to. But if you're going to look at the economic balance on safety, then show me, well, I reduced ICU usage and was able to fill those beds, but by other people lingering more, costs went up. And again, this ICU beds filled rubric, which has been used in some of these studies, does that mean that if you don't have the ability to backfill those beds, that you should not implement patient safety initiatives? I mean, it's a slippery slope. If you want to use the economic argument, then either use it honestly, use it thoroughly, use it the same way you would look at buying sponges, or don't use it. And that brings me to the last slide here. The bottom line is culture change, right? And that's really the key. When I wrote Demanding Medical Excellence, what truly depressed me was that most of the quality and safety interventions were not ones that we technologically did not know how to do. They really required only organizational commitment, really. And this is a picture of Betsy Lehman, whose death was disclosed by the Boston Globe, where she was a medical columnist, in March of 1995. And the outrage over that death, which was at a prominent Boston Cancer Hospital, Dana-Farber, where she was a patient, where her husband worked, caused the kind of change and frankly, soul-searching by some of the most prominent physicians in the country that led to the launching of the modern patient safety movement. At the time that I'd been writing about this, at the time of the Betsy Lehman case, I personally did not know anyone who was a victim. And yet I was deeply moved and profoundly disturbed by the inertia that I saw in this area. And since then, like many of you, this movement has made some progress, absolutely, and come out of the closet, and we've broken through some of the silence. I think all of us can probably envision mothers and fathers and husbands and wives we know who have lost children or spouses or people who have lost their parents. And those are the people we need to keep in mind. You know, I'm going to close by noting one of the phrases that one will see when you read these economic analyses. And we don't even think about it. It says hospitals need to be encouraged, or payers need to share responsibility with hospitals. There's no such thing as a hospital. There are only people, executives, who run hospitals. There are only chief executive officers and medical officers and financial officers and nurses and board members, people from the community, who comprise the group that makes decisions for the hospitals, or similar folks who make decisions for insurance companies or for government. It's people who make these decisions, not bad people at all, dedicated people, but people who are not regularly confronted by their duty and find, just by force of habit, they're following their interest. I think that we who are involved in this movement will make some progress by appealing to interest, but will make faster progress by combining interest. Yes, incentives need to be aligned with duty, with the moral duty, with the moral imperative to do what we know how to do, what we have for years known how to do, and to do it now, quickly as we can, as quickly as is possible, not as quickly as is financially desirable. So that's really how I come out on this, and I welcome your questions.
But let me start off with a real quick question. One is that I found when reading the articles, when you talk about cost savings, sometimes it's a confusion if it's a cost savings to the insurance company or actually a cost savings to the hospital.
Correct.
And the other problem is that hospitals have fixed costs. So you may actually save costs, but it's actually more of a savings to them to have a filled bed at a loss than an empty bed, because they lose a lot more then.
Absolutely. You know, I have a friend who is a financial consultant to hospitals, and once he was talking to me about how a chief financial officer had said something to him about too many scans with an MRI, and he was indignant that they were worrying about all those clinical things when they had fixed costs, and they ought to just worry about the fixed costs and forget about the other stuff. And you're absolutely right about that.
Yeah, and that's hard. And then the other thing is the different payment systems. There's a line item payment system, and there's DRG, and Medicare's DRG system, where it's pretty much a flat fee, which is why the non-payment for hacks, I think, is very ineffective. It just affects now and then a comorbidity factor being billed. But the overall problem there is with the DRG is, yes, infections, let's say ventilator-associated pneumonia, may cause increased costs. But on the other hand, if the patient dies, they get the DRG full payment. So a lot of times it's a stop loss. I know that's, I actually had a letter published in the New England Journal of Medicine on that. It's kind of a morbid way of looking at things, but the DRG doesn't necessarily assure quality.
I think it's very, I'm really glad you brought that up, because it's appropriate. If you're going to write articles that claim to be economic analyses, then you need to be honest about death and injury and fixed costs and all the rest of this. I understand that the people who are writing these articles are in some ways writing it out of an interest in causing a particular outcome to happen. But, you know, in theory, when we write for the peer-reviewed medical literature, you're not trying to come up with a conclusion in advance. And I think those are all excellent points that you brought up.